Oropharyngeal dysphagia, inability to properly transfer food from mouth to pharynx, food stuck in throat not esophagus. Etiologies: stroke, advanced dementia, oropharyngeal malignancy or neuromuscular disorder like myasthenia gravis. Complications: aspiration pneumonia and weight loss. Videofluoroscopic modified barium swallow study preferred initially to evaluate swallowing mechanics, degree of dysfunction and severity of aspiration. Esophageal motility disorders. Achalasia and pseudoachalasia, both present with dysphagia to solids and liquids with smooth tapering of lower esophagus. Achalasia, loss of peristalsis in distal esophagus with lack of lower esophageal sphincter relaxation, SX45YRS before receiving diagnosis and mild weight loss. Endoscopy. In achalasia, this evaluation usually shows normal, appearing esophageal mucosa and a dilated esophagus with possible residual material. In addition, it is generally possible to easily pass the endoscope through the lower esophageal sphincter, unlike in malignancy, RX, laparoscopic myotomy and pneumatic balloon dilation. Rightward arrow treatment of choice in PTS with low risk of surgery. PTS with high risk of surgery: rightward arrow botulinum toxin injection, nitrates and calcium channel blockers, but exclude malignancy first. Pseudoachalasia, due to esophageal cancer not due to denervation, rapid symptom onset, 6 MO, significant weight loss, alcohol and tobacco history, age 60, perform rightward arrow endoscopic evaluation to exclude malignancy. Rightward arrow later CT for staging, and CT can also be performed if endoscopy is unrevealing and there is high suspicion of malignancy. Diffuse esophageal spasm. Due to impaired inhibitory innervation in esophagus, often seen in association with emotional factors and functional GI disorders, SX resemble achalasia, impaired relaxation of lay and nutcracker esophagus, excessive tone at lay, endoscopy usually normal. Dyspepsia causes: GERD, nonsteroidal anti-inflammatory drugs, gastric or esophageal cancer, functional dyspepsia, and symptomatic Helicobacter pylori infection, with or without peptic ulcer. Management: PPI or H2 receptor blocker, preferably PPI. PTS who fail to improve with RX regardless of alarm SX. Indications for H. pylori testing, PT with upward arrow risk of H. pylori, such as those living in regions with high prevalence or household exposure, may elect for test and treat strategy. Breath test and stool antigen tests are done and not serology. GERD evaluation and treatment: typical GERD without alarm symptoms, dysphagia, odynophagia, weight loss, anemia, GI bleeding, recurrent vomiting. Rightward arrow trial of daily PPI. Rightward arrow refractory. Rightward arrow change PPI or upward arrow use of PPI twice daily. Rightward arrow persistent. Rightward arrow endoscopy or esophageal pH monitoring, typical GERD with alarm symptoms, dysphagia, odynophagia, weight loss, anemia, GI bleeding, recurrent vomiting, or men 50 with chronic, 5 years, symptoms or cancer risk factors, e.g. tobacco use. Rightward arrow endoscopy before trial. Rightward arrow esophagitis due to autoimmune or Barrett's esophagus. Rightward arrow treat accordingly, not esophagitis. Rightward arrow further evaluation, E.G. manometry. Complications: Barrett's esophagus, erosive esophagitis and esophageal, peptic, strictures. Benign strictures affect 5 to 15% of PTS with GERD. Other causes of esophageal strictures: radiation, systemic sclerosis and caustic ingest ions. Progressive dysphagia to solids without anorexia and weight loss leads to improvement in heartburn. Symmetric circumferential narrowing on barium swallow in any case of stricture. In case of Barrett's esophagus, biopsy is necessary to rule out adenocarcinoma. This is done via endoscopy, which may be diagnostic and therapeutic. Dilation is done if malignancy is not found. Globus sensation, hystericus. Globus sensation is a functional disorder of the esophagus characterized by the sensation of a foreign body in the throat. It is often worse when swallowing saliva and is frequently associated with anxiety. Pain, dysphagia. Dysphagia, dysphonia, or systemic symptoms are not typical for globus and suggest another condition. Pill esophagitis due to acid effect. Disruption of normal gastroesophageal protection, osmotic tissue injury, SX, sudden onset odynophagia and retrosternal pain, rightward arrow, difficulty swallowing, common in mid-esophagus due to its compression by aortic arch or enlarged left atrium, DX, clinically but can be confirmed on endoscopy, rightward arrow, discrete ulcers with normal, appearing surrounding mucosa, RX, stop offending med to prevent future injury. Esophageal rupture. Secondary to endoscopy, most common cause of esophageal rupture, ESP. If performed with other interventions like dilation of stricture, life-threatening and requires emergent evaluation, water-soluble contrast is preferred, less inflammatory to tissues, rightward arrow non-diagnostic, rightward arrow barium study, higher sensitivity, RX, if perforation is confirmed, rightward arrow primary closure of esophagus and drainage of mediastinum urgently to prevent development of mediastinitis. Characteristics of gastroesophageal mural injury or blunt abdominal trauma. PE, can be nonspecific but usually shows fever. Rapid progression, tachypnea, tachycardia, cyanosis U/L, usually left with or risk factors, hiatal hernia without pneumothorax, mediastinal widening, canand, alcoholism, longitudinal laceration on endoscopy, mucosal tear in stomach or esophagus. With electrocoagulation or local injection of epinephrine be seen as air and fluid. Accumulate in mediastinum, rightward arrow, inflammation, mediastinitis, amylase due to saliva in esophageal content may also contain food particles. Esophageal carcinoma. Adenocarcinoma, smoking, high dietary calorie or fat intake, medications that promote GERD-SCC, dietary deficiency of beta-carotene, vitamin B1, zinc, selenium, environmental viral infection, toxin-producing fungi, hot food and beverages, pickled vegetables and food rich in N-nitroso compounds etc. For definitive diagnosis, ESP. Start with this in PTS 55YRS or with alarm SX like weight loss, gross or occult bleeding, and early satiety. Young, low risk PTS may first go for barium esophagogram, RX, surgery for definitive cure in PTS with limited disease, upper GI bleeding, hematmesis, melena, anemia, bun/creatinine ratio 20, bun upward arrow because of upward arrow intestinal hemoglobin breakdown and upward arrow urea absorption in proximal renal tubule due to associated hypovolemia. Bun upward arrow in upper GI bleeding and not lower GI bleeding. Management. Supportive management includes supplemental oxygen, bowel rest, and 4 fluid infusion via large bore catheters, 4 ppi for acid suppression, also reduce rebleeding and need for transfusion and help stabilize clot UGIB. H2 receptor blockers have no such benefit. Packed RBC transfusion, rightward arrow upward arrow oxygen carrying capacity. Recommendation/threshold for packed RBC transfusion. And hypovolemia, higher threshold for this due to initial HB concentration not fully reflecting blood loss. Also HB concentration may drop significantly as blood volume is replaced by crystalloid solutions and mobilization of interstitial fluids. Recommendations for infusion of fresh frozen plasma, contains all clotting factors and plasma proteins from 1 unit of blood, indicated for severe coagulopathy, e.g., liver disease, DIC, with active bleeding, generally not indicated to correct. Minimally abnormal INR, 1.6. Recommendations for platelet transfusion, given for platelet count 10,000/mm3 because of upward arrow risk of spontaneous hemorrhage, given for platelet count 50,000/mm3 with active bleeding. Recommendations for whole blood transfusion, I.E. PRBC with plasma, in severe hemorrhage, e.g. massive trauma, requiring massive transfusion to assist in volume expansion. Acute erosive gastritis, severe hemorrhagic erosive lesions, etiology, exposure of gastric mucosa to injurious agents or substantial downward arrow in blood flow. Aspirin rightward arrow causes downward arrow in protective PG and direct mucosal injury. Alcohol also causes direct mucosal injury and so aggravates aspirin effect. Mucosal injury rightward arrow downward arrow protective barrier, I.E. Downward arrow bicarb and mucins and downward arrow epithelium integrity. Rightward arrow allow acid and luminal subs, proteases and bile acids, to penetrate to lamina propria. Rightward arrow further injury to vasculature and subsequent hemorrhage. Rightward arrow hematmesis and abdominal pain. Gastric carcinoma, gastric adenocarcinoma. Important to reveal mets ESP. Liver mets. Laparotomy is eventually required for curative or palliative management in most patients, but initial CT imaging is needed to plan the appropriate next steps in evaluation. H. pylori is important cause of adenocarcinoma and eradication is recommended before cancer removal to avoid future adeno-CA development. Treatment leads to remission in some MALtoma cases but not adeno-CA. Mucosa-associated lymphoid tissue lymphoma, MALT lymphoma, low-grade MALtoma have high association with H. pylori. Treatment of H. pylori with antibiotics may regress MALtoma and is mainstay of gastric MALtoma without mets. Rightward arrow no regression. Rightward arrow chemotherapy with CHOP, cyclophosphamide, adriamycin, vincristine, prednisone, or CHOP plus bleomycin. Role of radiotherapy is controversial and currently being used as adjunctive therapy. Gastric outlet obstruction, post-prandial pain and vomiting with early satiety, causes, gastric malignancy, peptic ulcer disease, Crohn disease, strictures, with pyloric stenosis. 2 to caustic acid ingestion usually develop after 6-12 weeks of ingestion after resolution of acute injury and gastric bezoars. Maneuver to diagnose gastric outlet obstruction, abdominal succussion splash, stent placed over upper abdomen and rock back end. 4th at hip rightward arrow retained gastric material 3 hours will generate splash indicating presence of gas and fluid in hollow. Viscous test has modest sensitivity and specificity but indicate need for more definitive evaluation. Initial management, nasogastric suctioning to decompress stomach, for hydration, and endoscopy for definitive diagnosis. Rx, surgery usually in case of stricture. Malabsorption syndromes causes of steatorrhea. Celiac disease can also lead to deficiency of VITB12, folic acid and zinc, DX, strongly correlated with positive IgA, anti-tissue transglutaminase AB and IgA anti-endometrial AB, but many PTS with biopsy-confirmed celiac have negative IgA antibodies screened due to concurrent selective IgA deficiency, which is common in celiac disease. If IgA serology is negative and suspicion is high, rightward arrow measure total IgA or IgG-based serologic testing should be done. D. Xylose absorption test. D. Xylose monosaccharide absorbed directly in proximal small intestine without degradation by pancreatic or brush border enzymes. Positive test, in proximal small intestinal mucosal disease, most common celiac disease. False positive, delayed gastric emptying or impaired glomerular filtration. Small intestinal bacterial overgrowth, rightward arrow fermentation of D. Xylose before absorption. Course of antibiotic, rifamycin, will improve D. Xylose absorption. Negative test, normal in pancreatic enzyme deficiency, Crohn disease, due to involvement of distal small intestine, lactose intolerance, pancreatic insufficiency, long-term alcohol abuse. Rightward arrow chronic pancreatitis. Rightward arrow progressive inflammation. Rightward arrow permanent structural damage. Rightward arrow loss of exocrine and endocrine. Function rightward arrow loss of 90%. Function rightward arrow fat and protein malabsorption. Rightward arrow postprandial epigastric pain, 15 to 30 minutes after meal, intermittent initially and later becomes persistent. DX, pancreatic function test to document pancreatic exocrine insufficiency, fecal fat tests, e.g., Sudan stain on spot stool specimen or 72-hour collection, confirm steatorrhea and can be used to monitor response to pancreatic enzyme replacement therapy. Tropical sprue, stay in tropical area, e.g. Puerto Rico, 4. 1 MO, malabsorption. Rightward arrow ESP. VITB12 and folate def. Glossitis, chelosis, protuberant abdomen, pedal edema, anemia, small intestinal biopsy. Rightward arrow blunting of villi, infiltration of chronic inflammatory cells, including plasma cells, lymphocytes, and eosinophils. Careful stool and serologic testing may still be required to exclude infection with Entamoeba histolytica, Giardia iamblia, Strongyloides stercoralis, Cryptosporidium parvum, and Isosporobelli. Lactose intolerance, characterized by a positive hydrogen breath test, positive stool test for reducing substances, not positive urine test for reducing subs. Urine test is positive in glucosuria, galactosuria, etc. Low stool pH, due to fermentation products, and increased stool osmotic gap, due to unmetabolized lactose and organic acids measured by 290, 2, stool Na plus stool K, osmotic gap upward arrow ES50 mosm/kg in all forms of osmotic diarrhea. There is no steatorrhea. Small intestinal bacterial overgrowth acid suppression, chronic pancreatitis. Normal level 104 organism/ml, SIBO is due to upward arrow in native and non-native bacteria that cause upward arrow fermentation, inflammation, and malabsorption. The proximal small intestine normally contains relatively minimal bacterial colonization due to gastric acidity and peristalsis. Other protective mechanisms against SIBO include bacterial degradation by proteolytic digestive enzymes, trapping of bacteria by intestinal mucus, and an intact ileocecal valve preventing retrograde bacterial movement from the colon. Hydrogen breath test using lactulose show an early peak in hydrogen levels due to rapid lactulose metabolism in the small bowel, normally broken down in the colon. Zinc deficiency, essential mineral, source, animal protein, whole grains, beans, and nuts, digested in jejunum. Risk factors for deficiency, TPN formulations that lack zinc, IBD-PTS are at risk because of impaired absorption, SX, alopecia, abnormal taste, bullous, pustulous lesions surrounding body orifices, and / or extremities and impaired wound healing. In children, it can lead to growth retardation. Selenium deficiency, like zinc deficiency, may result from chronic TPN. It may also result from malabsorption or malnutrition. Food sources include nuts, meat, and fish. The most important feature of deficiency is cardiomyopathy. Collagenous colitis. Collagenous colitis is an uncommon disorder producing chronic watery diarrhea. The colon is frequently involved, but colonoscopy shows normal mucosa. Biopsy shows mucosal subepithelial collagen deposition. Irritable bowel syndrome. Common in young women. Most common GIDX in North America, can also present with non-specific symptoms of GERD, dysphagia, early satiety, and chest pain. Earlier DX of exclusion now, based on Rome 3 criteria, no alarm symptoms or FH of IBD or colorectal CA. Rightward arrow need no further workup. Inflammatory bowel disease. IBD has bimodal distribution, most present in 20s to 30s with second peak around 60s. Neutrophilic cryptitis is seen in both conditions. Crohn disease non-casating. Granulomas, pathognomonic, 60% cases. Granulomas also found in GITB, sarcoidosis, and Yersinia infection. Transmural involvement, skip lesions, cobblestone appearance of colon, creepy fatty appearance of mesentery, fistulas, fissures, and perianal disease. String sign due to bowel wall thickening, abdominal pain and bloody diarrhea, more common in ulcerative colitis. No granulomas, crypt abscesses and ulcer, characteristic, mucosal and submucosal involvement only. Lead pipe appearance. Pseudopolyps, inflammatory polyps due to chronic disease may be present in CD, abdominal pain and bloody diarrhea UC, but can occur if disease involves colon, usually one of the two patterns. Fibrostenotic obstructing pattern or penetrating fistulous pattern may involve any part from mouth to anus, but usually limited to terminal ileum. May cause solitary colitis in 15 to 20% patients. Rectum generally spared, limited to colon and rectum. Always involved, sometimes may involve terminal ileum. Basquash ileitis. Ulcerative colitis. Risk of melanoma and other non-melanoma to skin cancers. Upward arrow in IBD due to immunosuppressive meds. Toxic megacolon. UC, usually limited to colonic mucosa, at times extend to smooth muscle layer. Rightward arrow paralysis of muscles. Rightward arrow colonic dilation, usually in early disease, usually 3 YRS of diagnosis, can be total or segmental colonic dilation. Other causes: ischemic colitis, volvulus, diverticulitis, infections, e.g. diff, CMV colitis in HIV PTS, obstructive colon cancer, less common, SX, severe bloody diarrhea, and systemic findings, DX, plain X-ray, showing dilated right or transverse colon, 6 cm, possible multiple air, fluid levels, thick house trowel markings that do not extend across entire lumen, and / 3 of the following: fever 38C, pulse 120/min, WBC 10,500/L, and anemia. Other findings can be volume depletion, altered mental status, hypotension, peritonitis, and electrolyte imbalance, RX, medical emergency. Rightward arrow nasogastric decompression, for hydration, broad-spectrum antibiotics, bowel rest. 4 corticosteroids preferred for treating IBD, toxic megacolon. Emergency surgery, subtotal colectomy with end, ileostomy treatment of choice, if colitis not resolved. 50% cases will respond to conservative management. Opioids are CI due to antimotility effect that can promote perforation. Discontinue other antimotility drugs like loperamide and anticholinergic agents. Minimal bright red blood per rectum, BRBPR. Unless they had normal colonoscopy 2 to 3 years back, usually due to hemorrhoids or rectal fissures. But can be due to serious causes like proctitis, rectal ulcers, colorectal polyps, cancer. Evaluation depends on PT's presentation and risk factors. Anoscopy is also useful in older PTS to visualize a palpable abnormality found on PE. Factitious diarrhea, due to laxative abuse, frequent, watery, and nocturnal diarrhea. Characteristic biopsy findings: dark brown discoloration of colon with lymph nodes shining through as pale patches, melanosis coli, ESP. In those using/abusing anthraquinone-containing laxatives, E.G. Bisacodyl, generally develop in 4 months of laxative ingestion and disappear in same time of discontinuation. Alternative way of diagnosis: histological evidence of pigment in macrophages of lamina propria diverticula of GI tract diverticulosis, association with chronic constipation, downward arrow fiber intake and upward arrow fat diet, rightward arrow upward arrow intraluminal pressure, rightward arrow diverticula. Conversely, altered motility in diverticular disease, rightward arrow constipation, most common in sigmoid colon but bleeding. Diverticula are usually on right side. Bleeding is usually painless, usually resolves spontaneously. minority require endoscopic or surgical intervention, upward arrow fiber, fruits and vegetables, rightward arrow unclear risk of diverticular formation. But downward arrow risk of acute diverticular complications, upward arrow risk of diverticular complications, diverticular hemorrhage and diverticulitis, upward arrow meat intake, aspirin, NSAID use, obesity, and possibly smoking, alcohol rightward arrow upward arrow diverticula formation but not upward arrow risk of diverticular complications. Acute diverticulitis leukocytosis. Inflammation due to microperforation of diverticulum, characterized as uncomplicated, 75%, and complicated, 25%, uncomplicated diverticulitis in stable PTS can be managed in outpatient setting by bowel rest, oral antibiotics, and observation, elderly, immunosuppressed, high fever or significant leukocytosis, or have significant comorbidities rightward arrow hospitalization and for antibiotics complicated, associated with abscess, perforation, obstruction, or fistula. Formation, abscess. Fluid collection 3 cm rightward arrow for antibiotics and observation rightward arrow surgery for PTS with worsening symptoms fluid collection 3 cm rightward arrow CT, guided percutaneous drainage rightward arrow if SX not controlled by 5th day rightward arrow surgical drainage and debridement, sigmoid resection reserved for PTS with fistulas, perforation with peritonitis, obstruction or recurrent attacks of diverticulitis 10 to 15% PTS have urinary frequency, urgency, dysuria due to bladder irritation from sigmoid colon inflammation CT scan. Inflammation in pericolic fat, presence of diverticula, bowel wall thickening, soft tissue masses, e.g. phlegmons, and pericolic fluid collection suggesting abscess, upright X, ratios nonspecific findings, barium enema, sigmoidoscopy, and colonoscopy rightward arrow CI in acute diverticulitis. Colonoscopy rightward arrow performed after resolution of acute diverticulitis to rule out CRC. Zenker diverticulum. Other C/FS, oropharyngeal dysphagia associated with neck mass, gurgling in throat, potential complications, tracheal compression, ulceration with bleeding, develop immediately above upper esophageal sphincter with posterior herniation between fibers of cricopharyngeal muscle, occurs due to upper esophageal sphincter dysfunction and esophageal dysmotility. Colovesical fistula usually occurs at end of urination as gas collects at the top of bladder shows contrast in bladder with RX, usually surgery after infection resolution thickened colonic and bladder walls. Mesenteric ischemia acute mesenteric ischemia. Urge to defecate. A.Fib. Cardiovascular aneurysm, shock, vasoconstriction, acute thrombosis due to peripheral arterial disease or low cardiac output states elevated HB, hemoconcentration, or low bicarb, most common in elderly, may result from cardiac embolus, A. Fib, arterial thrombus, atherosclerosis, or other etiology, as in shock or vasoconstriction. Periumbilical abdominal pain can be associated with N/V out of proportion to PE findings rightward arrow if prolonged rightward arrow more focal abdominal tenderness, due to local inflammation/infarction, perforation, or peritonitis, or peritoneal signs, e.g. guarding, rebound tenderness, CT, focal or segmental bowel wall thickening, pneumatosis intestinalis. Small bowel dilation, mesenteric stranding and mesenteric thrombi, management, patients with evidence of bowel infarction rightward arrow undergo immediate operative evaluation, otherwise, diagnosis can be confirmed radiologically by CT angiography. Treatment includes open embolectomy with vascular bypass or endovascular thrombolysis. In addition, patients should be started on broad-spectrum antibiotics and, in the absence of active bleeding, anticoagulation to reduce the risk of clot expansion. Chronic mesenteric ischemia. May also complain of nausea, early satiety, and diarrhea. Pain starts within first hour of eating and resolves within next 2 hours. Abdominal X-ray and CT may show calcified vessels. Diagnosis require better calcification. Ischemic colitis. Fever. Nausea. Leukocytosis. CT scan with 4 contrast is performed urgently to assess immediate need for surgery. Rightward arrow I.E. Extensive bowel damage, perforation, gangrene. Rightward arrow if surgery not needed. Rightward arrow colonoscopy to confirm DX, commonly involved sites, splenic flexure at watershed line BTW territory of superior and inferior mesenteric artery and rectosigmoid junction at watershed BTW sigmoid artery and superior rectal artery. Retroperitoneal hematoma, back pain, hemodynamic instability, anemia, weakness, dizziness, PT on anticoagulation, normal or supertherapeutic INR. Rightward arrow raise suspicion. For retroperitoneal hematoma, rightward arrow perform abdominal CT. Rightward arrow ISO dense area in retroperitoneum. The risk of bleeding while on warfarin therapy is greatest in patients with risk factors such as diabetes, age 60, hypertension and alcoholism. Angiodysplasia, due to dilated veins and arteriovenous malformation, upward arrow incidence after 60, common in right colon but can occur anywhere, more frequently diagnosed in PTS with advanced renal disease and VW disease due to upward arrow bleeding tendency. Aortic stenosis, also upward arrow ES risk due to acquired VWF deficiency, from disruption of VW multimers as they traverse the turbulent valve space induced by, as has been reported to, remit after valve replacement, DX, endoscopy but may not be diagnosed properly due to poor bowel prep or location behind a house trowel fold, RX, asymptomatic. Rightward arrow no treatment needed. Anemia or gross or occult bleeding. Rightward arrow endoscopic cautery, usually colonic polyps. A polyp is a grossly visible protrusion from the flat mucosal surface of the intestine. Most polyps are benign. Classification of polyps. 1. Hyperplastic polyps, most common non-neoplastic polyps in the colon. Arise from hyperplastic mucosal proliferation. No further work up needed. 2. Hamartomatous polyps, include juvenile polyp, a non-malignant lesion, generally removed due to the risk of bleeding, and Putzjäger's polyp, generally non-malignant. 3. Adenoma, most common type of polyp found in the colon. Present in approximately 30 to 50% of elderly people. These polyps are potentially premalignant, however, 1% of such polyps become malignant. Most polyps are asymptomatic, less than 5% of patients have positive occult stool tests. The probability of an adenomatous polyp progressing into cancer can be judged clinically by the lesion's gross appearance, histology, and size. 1. Adenoma can be sessile or stalked, pedunculated. Cancer is seen more commonly in sessile polyps too. Histologically, adenoma is divided into tubular, tubulovillous, and the villous variety. Villous adenomas, which are most commonly sessile, are most likely, 3 times more likely than tubular adenoma for malignant transformation, to become malignant among all 3 varieties. Second on the list is tubulovillous, followed by tubular adenoma with the least risk of malignant transformation. Therefore, as the villous component increases, the risk of malignancy increases. 3. The likelihood of an adenomatous lesion containing invasive cancer also depends on the size of the polyp. The risk is negligible, 2%, with 1.5 cm polyp, intermediate, 2 to 10%, with 1.5 to 2.5 cm size polyp, and substantial, 10%, with polyps 2.5 cm in size. Lynch syndrome. Lynch syndrome is also known as hereditary non-polyposis polyposis colorectal cancer, HNPCC. To aid its diagnosis, the International Collaborative Group on Hereditary Non-Polyposis Colorectal Cancer established criteria known as the Amsterdam Criteria I-1. At least 3 relatives with colorectal cancer, one of whom must be a first-degree relative of the other 2. Involvement of 2 or more generations 3. At least 1 case diagnosed before age 54. Familial adenomatous polyposis has been excluded. HNPCC is also classically divided into 2 subgroups on clinical grounds. 1. Hereditary site-specific colon cancer, Lynch syndrome I. 2. Cancer family syndrome or Lynch syndrome 2. Lynch syndrome 2 is distinctly associated with a high risk of extracolonic tumors, the most common of which is endometrial carcinoma, which develops in up to 43% of females in affected families. Also associated with ovarian and skin cancers. Colorectal cancer screening. Also repeat after 5 years if 1 to 2 small adenomatous polyps are found and rectum autosomal dominant mutation in APC gene 100% risk of cancer if not appropriately treated with procticolectomy, colonic dysplasia rightward arrow upward arrow risk of adenocarcinoma rightward arrow prophylactic colectomy advised, normally done in all PTS/50 yo. Methods of screening. Screening can be performed using high sensitivity fecal occult blood testing, FOBT, annually, flexible sigmoidoscopy every 5 years combined with FOBT every 3 years, or colonoscopy every 10 years. Cirrhosis. Common causes of cirrhosis. Alcoholic hepatitis equals AST alt, ratio 2:1, NAFLD equals alt AST, L equals lipids. If AST alt in NAFLD rightward arrow suggests progression to advanced fibrosis and cirrhosis. If PT has mildly abnormal LFTs rightward arrow obtain drug and alcohol HX, family HX, blood transfusion HX, travel outside US, high-risk sexual practices rightward arrow if taking drugs or alcohol rightward arrow discontinue offending agents rightward arrow repeat LFTs rightward arrow still upward arrow after 6 months rightward arrow I.E. Chronic rightward arrow test for Hep B and C, hemochromatosis, iron studies/HFE protein analysis, fatty liver rightward arrow unremarkable rightward arrow search for muscle disorders like polymyositis and thyroid disease, drugs that cause upward arrow in LFTs, NSAIDs, antibiotics, HMG, CoA reductase. Inhibitors, antiepileptic drugs, antituberculous drugs, herbal preparations. Clinical features of cirrhosis. Hypogonadism is due to either primary gonadal injury or hypothalamic pituitary dysfunction, liver rightward arrow responsible for making serum binding proteins rightward arrow liver dysfunction rightward arrow downward arrow serum binding proteins rightward arrow downward arrow total T3 and T4, as most T3 and T4 is in bound form, and normal free T3 and T4 and normal TSH. All cirrhotic PTS should undergo surveillance USG every 6 mo to exclude any liver masses irrespective of the cause. Ascites causes. Evaluation, diagnosis confirmed via clinical, laboratory, and radiologic evaluation, abdominal USG needed to evaluate for complications, E.G. Splenomegaly, HCC, paracentesis is recommended in new onset ascites to determine etiology. Liver biopsy is required if diagnosis of cirrhosis is unclear or will alter course of management. Ascites fluid characteristics. SAAG equals serum albumin, ascites albumin, it is gradient not ratio, treatment of ascites 1. Start with Na plus and water restriction, 2L/day, 2. Diuretic therapy, if needed rightward arrow start with spironolactone leads to upward arrow in capillary hydrostatic pressure. Downward arrow liver synthetic function is indicated by downward arrow serum albumin, which can cause edema in later stages of liver failure, and upward arrow PT/INR upward arrow capillary permeability. 3. When maximal dose of spironolactone fails to improve rightward arrow, add loop diuretic, e.g. furosemide. Aggressive diuresis, 1L/day, rightward arrow not recommended. Cox of risk of hepatorenal syndrome. 4. Does not respond. Rightward arrow slow tapping of 2 to 4L/day of acidic fluid, without albumin infusion, but renal function is regularly monitored. Rightward arrow less aggressive paracentesis in PTS with borderline renal function. Hepatic hydrothorax, pleural effusion due to ascites, due to defect in diaphragm, right-sided more common. Best option for treatment, liver transplant. Primary treatment, thoracentesis followed by diuresis and salt restriction. Rightward arrow no response. Rightward arrow tips contraindicated. Rightward arrow pleurodesis, surgical portosystemic shunts have more morbidity. Esophageal varices. Variceal hemorrhage develop in 1/3 PTS with esophageal varices, and varices occur in almost 50% cirrhotic PTS. All PTS with cirrhosis should undergo diagnostic endoscopy to exclude varices, determine risk of variceal hemorrhage, and indicate strategies for primary prevention. Prophylaxis, small, non-bleeding esophageal varices. Rightward arrow all PTS should receive prophylaxis. First line, non-selective beta blockers, e.g. propranolol, nadolol. Rightward arrow downward arrow risk of progression to large varices and variceal hemorrhage, improve mortality due to bleeding and overall. MOA, downward arrow adrenergic tone in mesenteric arterioles. Rightward arrow unopposed alpha, mediated vasoconstriction and downward arrow portal venous flow. Second line, endoscopic variceal ligation in those with CI to beta blockers. Treatment of variceal bleeding, endoscopic sclerotherapy. It has no role in prophylaxis. Octreotide long-acting somatostatin analog. Rightward arrow downward arrow glucagon and downward arrow release of vasodilator hormones. Rightward arrow splanchnic vasoconstriction and downward arrow portal blood flow. Rx of active variceal bleeding, no role in prophylaxis. 2 large bore 4 needles or central line, downward arrow risk of aspiration by protecting airway and nasogastric decompression. Or terlipressin, a synthetic analog within 12 hours of vasopressin, or somatostatin. Control of bleeding is established in 80% PTS. Rightward arrow rebleeding is very common. ESP. In 6 weeks of initial hemorrhage, examples of temporary balloon tamponade, Sengs taken, Blackamore, Minnesota, Linton, Necklace tubes, coagulopathy, thrombocytopenia, and anemia are common complications and may also need correction. Blood transfusion will be needed if HB falls 9G/DL. Regularly monitor blood counts. Fresh frozen plasma for correction of coagulopathy but can cause volume overload. Platelet transfusion if platelet count 50,000/mm3. Hepatorenal syndrome, one of the most dangerous complications of end-stage liver disease, occurring in up to 10% of patients with cirrhosis. Characterized by decreased GFR in the absence of shock, proteinuria, or other clear cause of renal dysfunction, and a failure to respond to a 1.5 L normal saline bolus and withdrawal of diuretics. Pathogenesis, thought to result from renal vasoconstriction in response to decreased total renal blood flow and vasodilatory substance synthesis. Liver cirrhosis. Rightward arrow portal HTN. Rightward arrow upward arrow synthesis of NO from splanchnic circulation. Rightward arrow systemic vasodilation. Rightward arrow downward arrow peripheral vascular resistance and BP. Rightward arrow renal hypoperfusion. Rightward arrow activate RAS, sympathetic system, and ADH. Rightward arrow Na+ and water retention. Rightward arrow worsen volume overload. Any factor that downward arrow glomerular capillary pressure. Rightward arrow acute downward arrow in glomerular filtration and precipitate hepatorenal syndrome. Types: Type 1, rapidly progressive, Most patients die within 10 weeks without treatment. Type 2 progresses more slowly, with an average survival of 3 to 6 months. The most common causes of death are infection and hemorrhage. Rx, no medicine has any proven benefit. Rightward arrow, upward arrow. Mortality on dialysis. Liver transplantation is the only intervention with established benefit. Similar to prerenal azotemia, and exclude intrinsic renal causes. Upward arrow. Serum creatinine, 1.5 mg/dl, and vary. Downward arrow. Urine sodium. Acute liver failure. Acute liver failure is defined as acute onset of severe liver injury with encephalopathy. And downward arrow. Synthetic function, INR =1.5, in a patient without cirrhosis or underlying known liver disease. Most important prognostic factor, PT, prothrombin time. Patients who improve, have downward arrowing transaminases, PT/INR and bilirubin. Most common causes: concurrent use of alcohol. Upward arrow. Propensity to develop hepatotoxicity from acetaminophen 10 times normal. Patients who progress, may have downward arrowing transaminases. Rightward arrow indicating downward arrow in functional liver tissue and worsening PT/INR and bilirubin. Rightward arrow indicate worsening synthetic function. Ischemic hepatopathy, rapid and massive upward arrow in AST and ALT, with modest upward arrow in alkaline phosphatase and total bilirubin. Hyperbilirubinemia is more severe in acute viral hepatitis, PTS, who survive underlying cause, e.g. septic shock or HF. Rightward arrow. LFTs return to normal within 1 to 2 weeks. Drug-induced hepatitis, drugs and toxins typically cause hepatic injury, either through direct toxic effects or through idiosyncratic reactions. Direct toxic effects, dose-dependent, short latent periods. Some examples of direct toxins include carbon tetrachloride, acetaminophen, tetracycline, and substances found in the Amanita phalloides mushroom. Idiosyncratic reactions, not dose-dependent and have variable latent periods. Some examples of pharmacological agents that cause idiosyncratic reactions include isoniazid, chlorpromazine, halothane, and antiretroviral therapy. Drug-induced liver disease can also be broadly categorized according to morphology. 1. Cholestasis, chlorpromazine, nitrofurantoin, erythromycin, and anabolic steroids. 2. Fatty liver, tetracycline, valproate, and anti-retrovirals. 3. Hepatitis, halothane, phenytoin, isoniazid, and alpha-methyldopa. 4. Toxic or fulminant liver failure, carbon tetrachloride and acetaminophen. And 5. Granulomatous, allopurinol and phenylbutazone. 6. OCPs cause changes in LFTs without evidence of necrosis or fatty change, while extrahepatic hypersensitivity manifestations like rash, arthralgias, fever, leukocytosis, and eosinophilia are common in patients with drug-induced liver injury. They are characteristically absent in cases of isoniazid-induced hepatic cell injury. Histologic picture is similar to viral hepatitis. Alcoholic hepatitis. Tender hepatomegaly. Cholangitis, may present with fever, RUQ pain, and jaundice, but more severe presentation, e.g. sepsis, and marked upward arrow in ALP, not AST, ALT ratio 2, diagnosed by RUQ-USG and upward arrow ferritin. Social history for confirming alcohol use and quantification and discussing substance abuse is important in diagnosis. PTS with IHH/O chronic alcohol use, 7 drinks/day or 100 g/day, sometimes develop symptoms after acute upward arrow in consumption. In addition, alcoholic liver disease is unlikely with light to moderate alcohol intake, 15 drinks/WK for men, 10/WK for women. A standard drink is equivalent to 12 ounces of beer, 5 ounces of wine, or 1.5 ounces of 80 proof spirits. 1 ounce equals 30 ml. Diagnosis: mainly clinical and no further investigation required in PTS with consistent history and lab values. PTS with risk factors for viral hepatitis need further investigation. ALT, AST will be 1000 in viral hep and acetaminophen intoxication usually does not upward arrow 500 in acute alcoholic hepatitis as well. AST ALT ratio /= rightward arrow thought to be due to hepatic death of pyridoxal 5-phosphate, an ALT enzyme cofactor. No correlation BTW degree of elevation and severity of disease, Rx, abstinence, supportive, e.g. hydration and nutrition support, and acid suppression. Prednisone for severe alcoholic hepatitis, liver biopsy helpful if diagnostic uncertainty. Non-alcoholic fatty liver disease. Most common in PTS with obesity and diabetes, weight loss and control of metabolic risk factors. Can range from bland steatosis to inflammation and necrosis, steatopatitis, and fibrosis and cirrhosis. Histology, resembles macrovesicular fat deposition, peripheral displacement of nuclei, same as alcoholic hepatitis. Pathogenesis, upward arrow transport of FFA from adipose tissue to liver, downward arrow oxidation of FFA in liver, or downward arrow clearance of FFA from liver, due to downward arrow VLDL production. It is frequently related to insulin resistance leading to upward arrow peripheral lipolysis, insulin downward arrow lipolysis in peripheral tissue, TG synthesis, and hepatic uptake of fatty acids. Hepatic FFA rightward arrow upward arrow oxidative stress and production of pro-inflammatory cytokines, e.g. TNF-alpha, and further contribute to insulin resistance by impairing insulin-dependent glucose uptake by liver and upward arrowing gluconeogenesis by liver, DX, made on the basis of laboratory and imaging studies. Confirmed on liver biopsy. Hepatic fibrosis develop in 40% PTS. Cirrhosis in 10 to 15% PTS, it is safe to give statins in NAFLD. Hepatic encephalopathy. Pathogenesis, inability of liver to break down ammonia rightward arrow urea. Other toxins may also be responsible. These neurotoxins stimulate inhibitory, E.G. GABA, and impairment of excitatory, E.G. Glutamate, pathways in brain, DX, upward arrow NH3 is diagnostic in symptomatic PTS with high clinical suspicion rightward arrow but nonspecific and may be upward arrow in asymptomatic PTS. EEG may show B/L synchronous downward arrow wave frequency and upward arrow wave amplitude rightward arrow non-specific and non-diagnostic. Management of hepatic encephalopathy medicines like sedatives. Non-absorbable disaccharides, lactulose, lactitol, preferred, colonic bacteria rightward arrow metabolize lactulose to short-chain fatty acids, lactic acid, acetic acid, rightward arrow converts absorbable ammonia to non-absorbable ammonium, an ammonia trap, and also cause catharsis. Antibiotics, like rifaximin, rightward arrow downward arrow ammonia producing bacteria added to lactulose if PT does not improve in 48 hours or monotherapy in those unable to take lactulose. Catharsis using any laxative may also be beneficial. Neomycin is an alternate therapy in PTS unable to take rifaximin. Cirrhotic patients usually malnourished and should not follow a protein-restricted diet. Protein-free diets rightward arrow cause a negative nitrogen balance rightward arrow increase mortality. Protein restriction recommended only in patients unable to tolerate protein intake, i.e., recurrent encephalopathy episodes after a high-protein diet. Diuretics normally improve ascites and peripheral edema in most PTS with cirrhosis. Some PTS may become diuretic resistant and unable to mobilize ascites rightward arrow instead develop progressive azotemia, electrolyte disturbance, hypokalemia, and he and still can have significant ascites and peripheral edema, poor oral intake rightward arrow intravascular volume depletion and worsening of metabolic alkalosis and hypokalemia. Hypokalemia rightward arrow upward arrow renal ammonia production. Metabolic alkalosis rightward arrow converts ammonium to ammonia. Hence, PTS with He and hypokalemia rightward arrow prompt potassium repletion and intravascular volume repletion, e.g. albumin, spontaneous bacterial peritonitis. Most common features abdominal pain less prominent than in other causes of peritonitis known as Wrighton trail test. Paracentesis is the test of choice for DX. These two are main diagnostic criteria: E. coli and Klebsiella most common, followed by streptococcal species. Keep a low threshold of suspicion. PTS with cirrhosis are normally hypothermic and 100F warrants investigation. Solid liver masses. Not associated with OCP use caused by hyperperfusion from anomalous arteries, common in young women. Other risk factors: pregnancy and anabolic steroid use. USG, well-demarcated hyperechoic lesion. CT, early peripheral enhancement. Biopsy, not recommended. RX, excision hepatic angiosarcoma, rare liver neoplasm in older men exposed to chemical products like vinyl chloride, inorganic arsenic compounds, thorium dioxide. Bilirubin metabolism. Hyperbilirubinemia in adults. To assess hepatic parenchyma and biliary ducts: biliary dilation rightward arrow extrahepatic cholestasis. Absent biliary dilation rightward arrow intrahepatic cholestasis rightward arrow test. Antimitochondrial of hereditary hyperbilirubinemia Gilbert syndrome, downward arrow production of UDP, glucuronyltransferase, occurs in PTS with no apparent liver disease. Mild unconjugated hyperbilirubinemia, 3 mg/dl, thought to be triggered by one of classic stresses like fasting, stress or illness, fat, free diet, physical exertion, RX, unnecessary. Mode of inheritance should be discussed to prevent unnecessary testing. Crigler-Najjar syndrome, very rare, autosomal recessive, type 1, results in significant neurological impairment, kernicterus, and death. UCB 20 to 25 mg/dl and can rise to 50 mg/dl. Rightward arrow not affected by 4-phenobarbital. Normal liver enzymes and histology. Phototherapy and plasmapheresis used for short-term curative treatment. Liver transplant, type 2, less severe. UCB 20 mg/dl. No neurological impairment. 4-phenobarbital improve bilirubin level. RX, unnecessary in mil cases. Periodic phenobarbital or clofibrate. Downward arrow bilirubin level if necessary. Dubin-Johnson syndrome, benign, defective liver transport system. Rightward arrow upward arrow conjugated bilirubin with direct bilirubin fraction 50% not associated with hemolysis, common in Sephardic Jews, can occur in all races and both men and women. Icterus evident. Rest of PE normal. Some may have non-specific SX like fatigue, abdominal pain, weakness. Icterus usually mild, only becomes evident in context of trigger like illness, pregnancy, or OCP use. Labs, usually unremarkable, including CBC and LFTs. Serum bilirubin usually range from 2 to 5 mg/dl, may be normal or as high as 20 to 25 mg/dl. Additional insight in evaluation: normal urinary coproporphyrin. They have normal total urinary coproporphyrin but will have 80% coproporphyrin IV/S. Normal individuals who have similar majority of coproporphyrin 3. Liver is strikingly black. Histology normal except dense pigments composed of epinephrine metabolites within lysosomes. No treatment needed. Excellent prognosis. Rotor syndrome, benign, defect in liver storage of conjugated bilirubin. Rightward arrow leakage into plasma. Rightward arrow. Chronic and mild hyperbilirubinemia of both conjugated and unconjugated bilirubin then develop. Normal LFTs, no pigmentation. Wilson disease, also known as hepatolenticular disease, diagnosed in young age. 5. 40 YRS, downward arrow formation and secretion of ceruloplasmin and decreased secretion of copper in biliary system. Rightward arrow, copper accumulates in hepatocytes. Rightward arrow, damages due to generation of free radicals. Rightward arrow, copper leaks and deposits in other tissues. Liver involvement may present as asymptomatic. Chronic hepatitis, fulminant hepatitis, portal HTN, or macronodular cirrhosis. Neuropsychiatric symptoms: Parkinson, like tremors, rigidity, ataxia, slurred speech, drooling, personality changes, depression, paranoia and catatonia, also associated with Fanconi syndrome, hemolytic anemia and neuropathy. DX, gold standard liver biopsy, copper 250 mcg/gram dry weight, confirmatory, downward arrow ceruloplasmin level, 20 mg/dl, plus upward arrow urinary copper excretion plus Kaiser-Fleischer ring, Rx, copper chelators, D, pencilamine, trientine, oral zinc, prevents copper absorption, fulminant hepatitis or decompensated liver disease, liver transplantation. Biliary tract diseases, evaluation of elevated alkaline phosphatase. Primary biliary cholangitis/cirrhosis, chronic, progressive liver disease. Rightward arrow, cholestasis and autoimmune destruction of intrahepatic bile ducts, most common in middle-aged women. Insidious onset, SX, pruritus and fatigue. Initial SX, as disease progresses. Rightward arrow, steatorrhea, jaundice, hepatomegaly, eyelids, anthelasma, portal HTN and osteopenia may develop. May be associated with other autoimmune diseases, antimitochondrial antibodies plus VE, Rx, ursodeoxycholic acid, UDCA, used in a no. Of cholestatic disorders, DOC in PBC start as soon as DX is made, whether symptomatic or asymptomatic, not useful in later stages. UDCA is hydrophilic bile acid. Rightward arrow, downward arrow, biliary injury by more hydrophobic endogenous bile acids. Also upward arrow, biliary secretion and has anti-inflammatory and immunomodulatory effects. Rightward arrow, delays histologic progression and improve SX and possibly survival. Advanced disease with severe liver damage or cirrhosis, liver transplantation, definitive cure, vanishing bile duct syndrome, rare, progressive destruction of intrahepatic bile ducts, histologic hallmark, ductopenia, pathophysiology, unknown, most common cause of ductopenia, primary biliary cirrhosis. Other causes: failing liver transplantation, Hodgkin's disease, graft versus host disease, sarcoid, CMV infection, HIV, and medication toxicity. Certain drugs associated with intrahepatic cholestasis, antibiotics, e.g. macrolides, OCPs, anabolic steroids. Primary sclerosing cholangitis. Upward arrow, ALP and bilirubin, hyper, gammaglobulinemia, upward arrow, serum IgM levels or atypical P, ANCA-I.E. ERCP or MRCP. Rightward arrow, beating liver biopsy, to determine disease stage and prognosis. Obliteration by moderate lymphocytic infiltrate, as the disease is progressive, and can lead to hepatic failure and portal HTN. Mean survival is 12 years after diagnosis if liver transplantation not performed. Cholelithiasis risk factors: gallbladder stasis, normal mechanism, proteins and fatty acids in duodenum. Rightward arrow, promote release of CCK, cholecystokinin. Rightward arrow, gallbladder contraction, PT on TPN or prolonged fasting. Rightward arrow, absent normal stimulus for CCK and gallbladder contraction. Rightward arrow, gallbladder stasis. Rightward arrow, sludge and gallstone formation. Small bowel, ileal resection, or ileal Crohn disease. Downward arrow, enterohepatic circulation of bile acids. Rightward arrow, altered hepatic bile composition. Rightward arrow, bile becomes supersaturated with cholesterol. Rightward arrow, cholesterol gallstone formation due to Upward arrow concentration of bilirubin conjugates and total calcium in gallbladder. Estrogen-induced gallstone formation, during pregnancy and OCP use. Estrogen rightward arrow upward arrow in cholesterol secretion, progesterone rightward arrow downward arrow bile acid secretion and slows gallbladder emptying. Upward arrow cholesterol saturation of bile rightward arrow gallstone formation. Management of gallstones. Gallstone ileus, DX, confirmed by abdominal CT rightward arrow gallbladder wall thickening, pneumobilia, and an obstructing stone, RX, surgical removal of stone and either simultaneous or delayed cholecystectomy. Biliary colic, secondary to gallstones, ingestion of large, ESP. Fatty, meal rightward arrow gallbladder contraction against obstructed cystic duct rightward arrow intragallbladder pressure upward arrow rightward arrow RUQ or epigastric constant pain, not colicky, N/V, right shoulder / subscapular discomfort rightward arrow gallbladder relaxation rightward arrow stone falls back rightward arrow pain resolves. Recurrent and resolution between episodes. Pain resolves in 4 to 6 hours, absence of abdominal tenderness, fever, and leukocytosis, no signs of inflammation present, unlike cholecystitis, acute cholecystitis, gallstone rightward arrow obstructs cystic duct, CBD obstruction will cause severe jaundice and very high alkaline phosphatase, rightward arrow inflamed gallbladder mucosa rightward arrow stasis rightward arrow bacterial overload rightward arrow ischemia leads to gangrene, perforation, generalized peritonitis, or circumscribed abscess. Other potential complications, cholangitis or chronic cholecystitis, in 90% cases gallstones plus VE, pain similar to biliary colic but lasts longer than 6 hours. Pain is colicky, fever, leukocytosis, tenderness to palpation, vomiting. Uncomplicated cholecystitis may lead to mild upward arrow in transaminases, total serum bilirubin from 1 to 4 mg/dl, and serum amylase without obvious CBD or pancreatic disease. Alkaline phosphatase usually not upward arrow without associated cholangitis or cholecystolithiasis, RX, supportive, NPO for antibiotics and analgesics. Laparoscopic cholecystectomy rightward arrow shortly after hospitalization and immediately in case of perforation or gangrene. Early removal rightward arrow downward arrow disease duration of hospitalization and mortality when compared to delayed, 7 days, cholecystectomy post-cholecystectomy syndrome, PCS refers to persistent abdominal pain or dyspepsia, e.g., nausea, that occurs either postoperatively, early, or months to years, late, after a cholecystectomy. Can be due to biliary, e.g., retained common bile duct or cystic duct. Stone, biliary dyskinesia or extrabiliary, e.g., pancreatitis, peptic ulcer disease, coronary artery disease, causes, functional or sphincter of Oddi dysfunction. Patients usually notice the same pain they had prior to surgery, new pain just after surgery, or the same pain that never went away. Laboratory findings can include elevated alkaline phosphatase, mildly abnormal serum aminotransferases, and dilated common bile duct on abdominal ultrasound. These findings usually suggest common bile duct stones or biliary sphincter of Oddi dysfunction, LFTs upward arrow during pain and come to normal level when pain subsides. The next step involves endoscopic ultrasound, endoscopic retrograde cholangiopancreatography, ERCP, or magnetic resonance cholangiopancreatography for final diagnosis and guiding therapy. Detect stone rightward arrow sphincter of Oddi manometry for sphincter of Oddi dysfunction, upward arrow pressure in this. Functional pain is diagnosis of exclusion. Treatment for PCS is directed at the causative factor. ERCP with sphincterotomy is the treatment of choice for sphincter dysfunction. Acalculous cholecystitis. These conditions cause gallbladder stasis or ischemia, with local Inflammation that can lead to gallbladder distension, necrosis, and 2 registered bacterial infection by enteric organisms. Complications: gangrene, perforation and emphysema, 2 cholecystitis, sepsis and death can occur. Radiologic signs: gallbladder wall thickening and distension and presence of pericholecystic fluid. Rx: immediate antibiotics followed by percutaneous cholecystostomy under radiologic guidance. Cholecystectomy with drainage of any associated abscesses. Definitive treatment once PTS condition improves. Emphysema 2 cholecystitis I.E. Immunosuppression, obstruction or stenosis of cystic artery. Gallstones. Sometimes pneumobilia, air within hepatobiliary system, due to Clostridium-induced hemolysis, life-threatening form of acute cholecystitis due to infection with gas, forming bacteria like Clostridium and some strains of E. coli. Complications: gangrene and perforation, latter may transiently relieve pain but later results in peritoneal signs. Acute cholangitis. Neutrophilia or open surgical decompression. If prompt treatment is not done, rightward arrow septic shock, bile duct obstruction from gallstones, malignancy, or stenosis, rightward arrow biliary stasis, rightward arrow acute cholangitis. In the setting of stasis, rightward arrow bile, blood barrier disrupts, rightward arrow translocation of bacteria and toxins from hepatobiliary system to bloodstream. Cholangiocarcinoma, SX of biliary obstruction, jaundice, pruritus, light-colored stools and dark urine. Risk factor: major is primary sclerosing cholangitis. Acute pancreatitis. Perform RUQ-USG for gallstones, rightward arrow non-diagnostic, ESP. If stone has passes, rightward arrow ERCP, rightward arrow but typically have upward arrow alt. ERCP should also be considered in PTS with 1 episode of acute pancreatitis of unknown origin. HIDA is not used to diagnose pancreatitis, rather used for cholecystitis. Serum Tg must be 1000 mg/dl to be considered potential cause of pancreatitis. Tg 1000 ischemic/atheroembolic mg/dl. Rightward arrow also leads to eruptive xanthomas. Rightward arrow DX, fasting lipid profile. Perform these tests in sequence. If these 2 are present, then court need not be performed unless diagnosis is unclear or after failure of conservative Rx to identify infection or necrosis. CXR abnormal in 1/3 PTS show atelectasis, elevated hemidiaphragm or pulm. Infiltrates due to activated pancreatic enzymes, e.g. trypsin, phospholipase, or cytokine, e.g. TNF, released from inflamed renal failure. Pancreas, chronic alcohol abuse and gallstones account for 75% of all cases. Early in pancreatitis, the pancreas synthesizes digestive enzymes but cannot secrete them. These enzymes leak out of the acinar cells into the systemic circulation. Amylase rises within 6 to 12 hours of symptom onset and may remain elevated for 3 to 5 days. Lipase rises within 4 to 8 hours of symptom onset but remains elevated longer than amylase, 8 to 14 days. As a result, lipase is more useful and sensitive than amylase for diagnosis, especially in alcoholics and patients presenting later in the disease course. Acute pancreatitis 2 degrees to atheroembolism, patients with risk factors for aortic atherosclerosis, E.G. Hypercholesterolemia, DM, PVD, who undergo cardiac catheterization or vascular procedure. Rightward arrow upward arrow risk of cholesterol emboli as a result of vascular manipulation. Emboli can occlude blood vessels and cause following: skin manifestations, livedo reticularis, reticulated, mottled, discolored skin, blue toe syndrome, kidney manifestations, acute renal failure, GI manifestations, pancreatitis, mesenteric ischemia. Treatment of uncorrectable causes of acute pancreatitis. Uncorrectable causes: ischemia, hypotension, viruses, atheroembolism. Supportive care: Pain control, 4 fluids, bowel rest. Most acute attacks are self-limiting and usually improve in 4 to 7 days of supportive care. PT should be NPO except essential medications like antiplatelet therapy in case of stent placement. Prophylactic antibiotics are not routinely used in acute pancreatitis unless there is evidence of necrotizing pancreatitis with local infection. Drug-induced acute pancreatitis, 5% cases of acute pancreatitis, medicines causing acute pancreatitis, anti-seizure medications, valproic acid, diuretics, furosemide, thiazides, drugs for IBD, sulfasalazine, 5, ASA, immunosuppressive agents, azathioprine, HIV-related meds, didenosine, pentamidine, antibiotics, metronidazole, tetracycline, usually mild N/V, abdominal pain radiating to back, upward arrow amylase and lipase. CT, peripancreatic fluid and fat stranding, RX, supportive fluid and electrolyte replacement. Chronic pancreatitis. Progressive inflammation of pancreas, rightward arrow, irreversible exocrine and endocrine dysfunction. Unlike acute pancreatitis, CP causes patchy inflammation and fibrosis. Burned out pancreas, rightward arrow normal or slightly upward arrow amylase and lipase. Early CP can present with acute attacks that become continuous as condition progressively worsens. Stool elastase marker for pancreatic exocrine function, low levels in CP rather than acute pancreatitis. Severe pancreatitis. Most PTS have mild disease. Rightward arrow recover with conservative management in 3 to 5 days. 15 to 20% develop severe acute pancreatitis, defined as pancreatitis with involvement of at least one organ. Severe pancreatitis, rightward arrow, local release of activated pancreatic enzymes. Rightward arrow enters vascular system. Rightward arrow, upward arrow, vascular permeability within and around pancreas. Rightward arrow, large volumes of fluid migrate from vascular system to surrounding retroperitoneum. Systemic inflammation also ensues as inflammatory mediators enter vascular system. Rightward arrow, widespread vasodilation, capillary leak, shock, and associated end organ damage. RX, supportive care with several liters of 4 fluid to replace intravascular volume. Complications of pancreatitis: pancreatic pseudocyst, progressive abdominal distension, abdominal pain, N/V, CT scan, round, well circumscribed, encapsulated fluid collection, usually no necrosis or solid material, thick fibrous capsule, containing enzyme, rich fluid, tissue, and debris. Upward arrow, serum amylase. Complications: spontaneous infection, duodenal or biliary obstruction, pseudoaneurysm, due to digestion of adjacent vessels, pancreatic ascites and pleural effusion. Abdominal imaging confirms diagnosis. RX. Minimal or no symptoms and without complications, e.g. pseudoaneurysm. Rightward arrow, expectant management, e.g. symptomatic therapy and NPO. Preferred initially significant symptoms: abdominal pain, N/V, infected pseudocyst, evidence of pseudoaneurysm. Rightward arrow, endoscopic drainage. Pancreatic cancer. Fourth leading cause of cancer death in U.S., adenocarcinoma, most common tissue type No. Of cigarette smoked. Alpha risk of pancreatic cancer, smoking cessation. Rightward arrow, downward arrow, risk by 25%. Usually occur after age 45, more common in men and African American. PTS, usually diagnosed late. Rightward arrow, high mortality, 98% according to some studies. Long standing DM. Rightward arrow, risk factor for pancreatic cancer. New onset DM. Rightward arrow, often a sign of occult pancreatic CA. Treatment of DM has variable effects on CA risk. Insulin and insulin secretagogues, e.g. sulfonylureas. Rightward arrow, upward arrow, risk of CA. Metformin. Rightward arrow, downward arrow, risk. Presentation and workup vary depending on tumor location. Classic findings: weight loss and insidious onset abdominal pain, worse at night, with eating, and when lying supine. Cancer of pancreatic head 60 to 70% jaundice. Bile duct obstruction, upward arrow. ALP and bilirubin steatorrhea. Pancreatic exocrine insufficiency or pancreatic duct blockage can lead to compression of pancreatic duct and common bile duct. Rightward arrow. Double duct sign on imaging. Backup of bile leads to dilation of intra and extrahepatic bile ducts and non-tender distended gall. Bladder, Courvoisier sign. Left supraclavicular LN enlargement, Virchow's nodes, can be present in metastatic disease. USG better for detecting pancreatic head tumor and excluding other causes of biliary obstruction, e.g. cholecystolithiasis. Rightward arrow if unremarkable. Rightward arrow perform CT scan. Rightward arrow non-diagnostic. Rightward arrow ERCP. Rightward arrow ERCP contraindicated. Rightward arrow percutaneous transhepatic cholangiogram, PTC. PTC is an invasive procedure in which a needle is inserted into a dilated bile duct and contrast material is injected for bile duct opacification. PTC is used in the evaluation of patients who have previously identified biliary tract dilation but are not candidates for ERCP. PTC also allows for certain therapeutic interventions, including the drainage of infected bile, in patients with cholangitis, extraction of stones in the biliary tract, dilation of benign biliary strictures, or stent placement across malignant strictures. Cancer of pancreatic tail and body do not present with obstructive jaundice. CT preferred to rule out other causes. USG less visibility of tail and body due to overlying bowel gas and also less sensitive for detecting smaller tumors, 3 cm, malignant biliary obstruction. Pharmacology. PPIS/E. C. Diff. Infection due to prolonged acid suppression also occurs in prolonged H2 receptor blocker use, prolonged acid suppression. Rightward arrow. Downward arrow. Calcium absorption. Rightward arrow. Osteoporosis, upward arrow. Colonization of pathogens in upper GI tract. Rightward arrow. Upward arrow. Risk of pneumonia. Contents water, soluble vitamin deficiencies. 3. Pediatric abdominal wall defect. 4. Umbilical hernia. 4. Gastroschisis. 4. Omphalocele. 5. Umbilical granuloma. 5. Differential diagnosis of crying infant. 6. Colic. 6. Foreign body ingestion. Ingestion. 6. Choanal atresia. 7. Congenital diaphragmatic hernia. 8. Anomalous vascular branches of aortic arch. 8. Esophageal atresia and tracheoesophageal fistula. 8. Esophageal atresia with tracheoesophageal fistula. 8. Isolated esophageal atresia. Atresia. 9. GI bleeding. 9. Milk protein allergy. 9. Meckel's diverticulum. 10. Intussusception. 11. Necrotizing enterocolitis. Enterocolitis. 13. Cyclical vomiting syndrome, CVS. 14. Differential diagnosis of vomiting and regurgitation in infants. 15. Gastroesophageal reflux. 15. Bilious emesis in neonates. 17. Volvulus. 17. Sigmoid volvulus. 18. Duodenal atresia. 18. Jejunal and ileal atresia. 18. Infantile hypertrophic pyloric stenosis. 18. Laboratory derangements in pyloric stenosis. 19. Cystic fibrosis. Fibrosis. 20. Hirschsprung disease vs meconium ileus. 20. Meconium ileus. 21. Hirschsprung disease. 21. Celiac disease. 22. Constipation. 23. Dehydration. 23. REYE syndrome. 24. Biliary cysts or choletical cysts. 24. Biliary atresia. 26. Physiologic jaundice. 27 Timeline of infant nutrition. 29 Breastfeeding. 30 Breastfeeding failure jaundice vs breast milk jaundice. 30 Breastfeeding failure jaundice. 31 Breast milk jaundice. 31 Beckwith-Wiedemann syndrome, BWS. 32 Gastroenterology-IM-SURGERY-MCCQE-V1 water, soluble vitamin deficiencies. Toxicity of water, soluble vitamins is rare, but pyridoxine excess can cause peripheral neuropathy. Pediatric abdominal wall defect. Umbilical hernia, incomplete closure of abdominal muscles around umbilical ring at birth, common in African American race, premature birth, Ehlers-Danlos syndrome, Beckwith-Wiedemann syndrome and hypothyroidism. Small umbilical hernias typically close spontaneously by concentric fibrosis and scar tissue formation. Spontaneous closure is less likely with large, 1.5 cm diameter, hernias or in patients with underlying medical problems. Surgery is recommended around age 5 for persistent hernias, or sooner if it is bothersome or causing complications. Gastroschisis, caused by vascular insult rightward arrow bowel herniation, second trimester USG rightward arrow 95% sensitive for abdominal wall defects and maternal serum AFP usually upward arrow ed. Gastroschisis rightward arrow bowel exposed to amniotic fluid rightward arrow inflammation and edema of bowel wall rightward arrow upward arrow risk of complications, e.g. necrotizing enterocolitis, short bowel syndrome, dysmotility, ileus, delayed gastric emptying, intolerance to feeds, occur in 50% cases and may prolong reliance on TPN. It is isolated defect in 90% cases. Rx, after delivery rightward arrow cover exposed bowel with sterile saline dressings and plastic wrap to minimize insensible heat and fluid losses. Rightward arrow place nasogastric tube to decompress bowel and start on antibiotic therapy. Therapy rightward arrow prompt surgical repair and can usually be accomplished in a single-stage closure. Omphalocele, approximate. Half of PTS with omphalocele have co-existing other defects like cardiac disease, neural tube defects, or trisomy syndromes. Rx, surgery immediately after birth by staged closure with a silastic silo. Umbilical granuloma, common cause of umbilical mass in newborns, appear after umbilical has separated. Rightward arrow present as soft, moist, pink, pedunculated, friable lesion. Rx, silver nitrate is treatment of choice. Differential diagnosis of crying infant. Crying time of a normal infant is generally 1 to 2 hours/day, but highly variable. Colic usually presents in first few weeks of life and spontaneously resolves by 4 months, generally cries at same time of the day. Etiology, cause unknown but may be due to overstimulation of baby and parental unfamiliarity with other soothing techniques. Parents report difficulty and frustration soothing the baby. Calming techniques, infant swing, swaddling, minimizing environmental stimuli, e.g. quiet, dark room, and holding and rocking baby. Review, feeding patterns to assess overfeeding, underfeeding, or an inadequate burping technique. Colic is associated with upward arrow incidence of non-accidental trauma, post-partum depression. Parents should be emotionally supported and reassured that their child is healthy and review soothing techniques. Breaks should be encouraged, including friend or family babysit the child. Foreign body ingestion, difficulty swallowing, feeding refusal and vomiting. Rightward arrow suspect foreign body ingestion. Management depends on object material, location in GI tract, timings of duration and symptoms. Coin, most commonly ingested material visualized in esophagus and symptomatic or time of ingestion unknown. Rightward arrow remove promptly with flexible endoscopy. Rigid endo has higher risk of perforation and abrasion reserved for impacted sharp objects. visualized in esophagus, and asymptomatic rightward arrow can observe for 24 hours after ingestion as coin lacks sharp border and metal not toxic. Those that reach stomach can be allowed to pass spontaneously. Radiolucent body, not visualized on X-ray, CT as next diagnostic procedure. Batteries, multiple magnets, or sharp objects, upward arrow risk of perforation. Obstruction, ischemia rightward arrow immediate endoscopy if object is visualized in esophagus. Severe symptoms like hematochezia, melena, and severe abdominal pain rightward arrow surgical removal. If battery is distal to esophagus, then almost 90% pass uneventfully. Rightward arrow observed to confirm excretion of battery by stool examination and / or radiographic follow-up. Avoid GI series rightward arrow as downward arrow visualization on endo, tracheobronchial foreign body aspiration. Suspect in toddlers with sudden wheezing, stridor, coughing or dyspnea. Rightward arrow rigid bronchoscopy procedure of choice. Choanal atresia. Pathophysiology, failure of posterior nasal passage to canalize completely, leaving either a bony, 90%, or membranous, 10%, obstruction. Narrowing is at the level of pterygoid plate in posterior nasal cavity, may be isolated or part of a syndrome, charge syndrome, coloboma, heart defects, atresia choanae, retardation of growth/development, genito, urinary abnormalities, and ear abnormalities / deafness. Clinical severity depends on child's ability to breathe from mouth, and whether one or both choanae is / are obstructed. C/F, B/L obstruction, classically presents with cyclic cyanosis that worsens when infants cannot breathe through the mouth, e.g., during feeding, and recovers when they do, e.g., while crying. U/L choanal atresia may remain undiagnosed until the development of a first URTI, DX, failure to pass catheter through nares into oropharynx confirmed by CT scan. In severe cases, air fluid levels may develop at obstruction. Site management. 1. Place oropharyngeal airway and orogastric tube feeding. 2. Definitive treatment, repairing obstruction with surgery or endoscopy. Congenital diaphragmatic hernia, presents as cyanosis and respiratory distress immediately after birth. Polyhydramnios can occur as a result of esophageal compression. However, the deviation of abdominal viscera into the thorax results in a scaphoid, appearing abdomen. In addition, X-ray shows a displaced cardiac silhouette, bowel in the thorax, and a gasless abdomen. Anomalous vascular branches of aortic arch. Anomalous vascular branches of the aortic arch can cause stridor and dysphagia due to compression of the trachea and esophagus. However, naso, or orogastric tubes can be advanced into the stomach. Esophageal atresia and tracheoesophageal fistula. Esophageal atresia with tracheoesophageal fistula, polyhydramnios due to inability to swallow amniotic fluid, excessive drooling, choking, coughing, and regurgitation with initial feeding attempts immediately after birth, inability to pass naso or orogastric tubes into stomach, presence of fistula. Rightward arrow air entry into stomach and intestines with each breath. Rightward arrow abdominal distension, gastric fluid can reflux into esophagus and through fistula to trachea and lungs. Rightward arrow aspiration. Pneumonia. Rightward arrow respiratory distress, crackles and infiltrates in lungs. 50% PTS with tracheal and esophageal anomalies have additional anomalies. Anomalies. Rightward arrow workup for bacterial, vertebral, anal atresia, cardiac, tracheoesophageal fistula, renal and limb anomalies, should be considered isolated. Esophageal atresia, rare and would not cause sudden respiratory distress with feeding. GI bleeding, divided into upper and lower GI bleeding by ligament of Treitz, upper GI bleeding, melena, black tarry stools from stomach and upper small intestine, lower GI bleeding, hematochezia, bright red blood, from distal small bowel and colon. D/D of hematochezia in toddlers, hemorrhoids, infectious colitis, intussusception, Meckel's diverticulum, most common, and inflammatory bowel disease. Milk protein allergy. Non-projectile vomiting, poor weight gain. Condition is exclusive to infants. Breast milk contains fats, carbs, e.g. lactose, and maternal diet-derived proteins, e.g. whey, 70%, casein 30%, from milk and soy. Protein content is higher at birth and downward arrow ES over first month of life. Whey is more easily digested and improves gastric emptying. Also contains lysozyme, lactoferrin, secretory IgA rightward arrow upward arrow immunity. Calcium and phosphorus are less in human milk than formula but better absorbed from breast milk. Non-IgE-mediated immunologic response to proteins in formula or breast milk rightward arrow causes rectal and colonic inflammation, DX, clinical and confirmed when bleeding ceases in response to dietary changes. Visible bleeding ceases in 3 days but occult blood may take up to 2 weeks. Reassure parents. Prognosis is excellent and almost all infants can tolerate dairy and soy products by 1 year, due to substantial cross-reactivity. Discontinue all dairy and soy products and continue breastfeeding after discontinuation. Meckel's diverticulum. Most common. 2% become symptomatic painless hematochezia being most common finding. Tiny amount of 4-technetium is given. Rightward arrow gamma camera highlights gastric mucosa and ectopic gastric tissue, approximate. 85% have heterotropic gastric mucosa and some have pancreatic tissue. Gastric mucosa secrete HCl. Rightward arrow mucosal ulceration of surrounding small bowel. Rightward arrow bleeding often substantial and causes severe anemia and hemorrhagic shock. Although bleeding usually stops on its own, surgical resection is necessary to prevent complications. Intussusception presents as severe, intermittent abdominal pain with or without hematochezia. Rightward arrow abdominal USG. Rightward arrow diagnostic and therapeutic air enema. Intussusception. (75% cases before 2 years, 6 to 36 MO, following viral infection. Rightward arrow enlargement of Peyer's patches in lymphoid-rich terminal ileum with no identifiable lead point in older children. Pathological lead point should be suspected ESP. In case of recurrence, Meckel being most common, occasionally palpable as a tubular sausage-shaped mass in RUQ, though ileocecal junction is in RLQ, but obstructive mass is found in RUQ, ileocolic junction most frequently involved. Telescoping is intermittent. Rightward arrow periodic pain associated with drawing legs towards abdomen. Emesis may follow episodes of abdominal pain. Rightward arrow initially non-bilious and later becomes bilious if obstruction persists. PE, occasionally intussusception is, air enema preferred as faster, cleaner and safer than contrast. Rightward arrow unsuccessful, pathological lead point identified or signs of perforation. Rightward arrow laparotomy. Necrotizing enterocolitis. Represents extravasation of bowel gas into damaged bowel wall, double line or train track appearance on X-ray, linear branching areas of lucency over liver portal, venous gas either due to bacteria producing gas in portal vein or by transmigration of gas from bowel wall. Rightward arrow mesenteric vein. Rightward arrow portal vein because of high risk of septic shock. Common sites, terminal ileum and colon. Term infants present earlier as enteral feeding starts earlier as compared to pre-term infants. Commercial formulas and mother's milk. Rightward arrow substrates for bacterial proliferation in gut. Rightward arrow poorly perfused intestinal wall. Rightward arrow downward arrow ability to digest and absorb nutrients. Rightward arrow bacterial fermentation. Rightward arrow excessive mucosal inflammation. Rightward arrow translocation of bacteria and gas into bowel wall. If possible, give mother's breast milk to premature infants as it counteracts some of the problems. leukocytosis and metabolic acidosis are signs of inflammation and intestinal ischemia. All neonates are frequently colonized by C. diff. But infection is rare in them, probably due to lack of toxin receptors. Cyclical vomiting syndrome, CVS. Recurrent predictable pattern of vomiting, family history of migraine headaches is often present, etiology, unclear but is thought to be linked to abdominal migraines, which generally present as abdominal pain as primary symptom. Some children progress from CVS to abdominal migraines and migraine headaches. Complications that may arise from recurrent vomiting, dehydration and anemia, Rx, hydration, antiemetics, e.g. ondansetron, and reassurance to parents. Children with FH of migraines are likely to benefit from anti-migraine therapy such as sumatriptan, approximate 2/3 have gradual resolution of symptoms in 5 to 10 years. Differential diagnosis of vomiting and regurgitation in infants. Gastroesophageal reflux, extremely common and affects 50% infants. Infants experience frequent postprandial regurgitation, e.g. spitting up or spilling, due to physiologic changes among adults and children. Differences shown in picture. If there is normal weight gain, growth, and development, no drop in growth percentiles, asymptomatic rightward arrow reassurance, supportive measures, and education of parents, frequent, small volume feeds, hold infant upright for 20 to 30 minutes after each feed. Place infant in prone position when awake, activities that upward arrow intra-abdominal pressure, e.g. fastening diaper too tight, brining knees to stomach. Avoid, improve by age 6 mo, when infant can sit unsupported, and resolves by age 1 year. Causes 1, 2, 3. Goat milk is deficient in folate. Rightward arrow macrocytic anemia. Bilious emesis in neonates. Volvulus usually present in first 2 days with failure to pass meconium. The primary predisposing factor for volvulus in children is malrotation of the midgut during early fetal development. Midgut volvulus classically presents in a neonate, age 1 month, with bilious vomiting. Initially, the abdomen is soft and not distended, but ischemia of the twisted bowel can cause bloody stools, bowel perforation, abdominal distension, and peritonitis. Signs of ischemia or systemic decompensation, i.e., shock, are an indication. Indication for emergency laparotomy. The evaluation of clinically stable neonates with bilious emesis begins with cessation of enteral feeds, nasogastric, NG, tube decompression, and intravenous, 4, fluids. An X-ray is generally the first step to rule out pneumoperitoneum, which would reflect intestinal perforation and immediate need for emergency surgery. Rarely, the diagnosis may be suspected if the NG tube terminates in the abnormally placed duodenum, but X-ray is usually nonspecific for midgut volvulus. If there is no evidence of free air and the bowel gas pattern is not suggestive of duodenal atresia, double bubble, or distal obstruction, dilated loops of bowel, then an upper gastrointestinal, GI, series I.E. Fluoroscopy, e.g., barium swallow, should be performed. An upper GL series is the fastest and most accurate method of diagnosing malrotation with midgut volvulus. The finding of the ligament of Treitz on the right side of the abdomen reflects malrotation, while contrast in a corkscrew pattern indicates volvulus. Surgery must be expedited to prevent catastrophic complications. If present, the volvulus is reduced. The LAD procedure consists of fixing the bowel in a non-rotated position to minimize recurrent volvulus risk. Serial abdominal X-rays are used to follow progression of non-surgical cases like ileus and mild cases of necrotizing enterocolitis, not recommended in suspected cases of surgical conditions like volvulus sigmoid volvulus, C/F, abdominal pain, distension, and constipation due to torsion of the sigmoid colon. X-ray shows an inverted U-shaped appearance of the distended sigmoid loop, coffee bean sign. This typically occurs in elderly patients and is exceptionally rare in children. Duodenal atresia, bilious vomiting within first 2 days of life, common in Down syndrome PTS. Due to failure to recanalize, surgical repair is the treatment. Initial RX in flow sheet. Pre-op cardiac assessment is extremely imp as 50% Down syndrome PTS have congenital cardiac anomalies ESP. VSD or ASD jejunal and ileal atresia, due to vascular accident in utero rightward arrow necrosis and resorption of fetal intestine rightward arrow sealing off and leaving behind blind proximal and distal ends of intestine. Risk factors: poor gut perfusion from maternal use of vasoconstrictive meds or drugs like cocaine and tobacco. Sometimes meconium ileus/cystic fibrosis rightward arrow inspissated meconium rightward arrow localized volvulus rightward arrow ischemic necrosis, not associated chromosomal abnormalities, X-ray, triple bubble sign and gasless colon, RX, resuscitation and stabilization rightward arrow surgical correction. Prognosis depends on length of affected bowel and PTS, gestational age and birth weight. Infantile hypertrophic pyloric stenosis, present at age 1 to 2 months, 3 to 5 weeks. Classic findings include visible peristaltic waves moving from left to right across upper abdomen just prior to emesis and a palpable abdominal mass. The classic olive-shaped abdominal mass is palpable in 50% of patients. It is best felt when the patient is calm after emesis, as the distended stomach can obscure the mass. However, the abdomen is soft and non-distended because minimal air can pass the gastric outlet. Laboratory derangements in pyloric stenosis. Formula feed rightward arrow slower gastric emptying and more consumption in less time, hence upward arrow gastric burden. Rightward arrow may lead to pylorus hypertrophy after feeding. Rightward arrow followed by hungry vomiter and hypokalemic. USG shows elongated, thickened pylorus and electrolyte normalization prior to surgery. Rightward arrow downward arrow ES risk of post-op apnea and improve overall outcomes. Cystic fibrosis. Hirschsprung disease vs meconium ileus. They should be considered in any infant who failed to pass meconium for 48 hours after birth, as 99% normal healthy infants pass stool within 48 hours. Meconium ileus, 20% PTS with CF develop meconium ileus, but all PTS with meconium ileus have CF. They also have narrow, underused/underdeveloped colon, microcolon, as obstruction is usually at the level of ileum. First step in management, abdominal X-ray is always first step to rule out pneumoperitoneum. 2* to perforation rightward arrow plus VE rightward arrow. Emergency surgery. VE pneumoperitoneum rightward arrow contrast enema to assess level of obstruction. Administration of hyperosmolar enema, e.g., gastrographin, can potentially break up the inspissated meconium and dissolve the obstruction. Surgery is required if therapeutic enema is unsuccessful. Almost all CF-PTS develop sinopulmonary disease. Rightward arrow opacification of all sinuses by 8-mo. Rightward arrow often require surgical debridement of their sinuses. Men typically infertile due to congenital absence of vas deferens, but only 20% females have fertility issues. 20% develop sensorineural hearing loss due to frequent use of aminoglycosides for GVE infections, e.g. Pseudomonas aeruginosa. Hirschsprung disease typically presents with increased rectal tone, squirt sign, forceful expulsion of stool after rectal examination, X-ray. Rightward arrow no perforation. Rightward arrow contrast enema. Rightward arrow transition zone at junction of narrow rectosigmoid and dilated colon. Rightward arrow rectal biopsy. Rightward arrow equivocal results. Rightward arrow anorectal manometry. Celiac disease. Constipation. Dehydration. Children are vulnerable to dehydration because upward arrow frequency of gastroenteritis, high surface area to volume ratio, rightward arrow, upward arrow, insensible losses, downward arrow, ability to communicate, stool burden, downward arrow, bladder capacity, rightward arrow, urinary incontinence and sit on toilet after each meal. Management. Initial step is to determine severity. Ideal method: determine measured change in weight. 1 kg acute weight loss equals 1 L fluid loss. However, weight changes frequently in children and it is difficult to determine. Determine last well weight. Hence, severity is determined by history and physical exam and divided into following categories. 1. Mild dehydration, 3 to 5% volume loss, a history of downward arrow intake or upward arrow fluid loss with minimal or no clinical symptoms. 2. Moderate dehydration, 6 to 9% volume loss, downward arrow skin turgor, dry mucous membranes, tachycardia, irritability, a delayed capillary refill, 2 to 3 seconds, and downward arrow urine output. 3. Severe dehydration, 10 to 15% volume loss, cool, clammy skin, a delayed capillary refill, 3 seconds, cracked lips, dry mucous membranes, sunken eyes, sunken fontanelle, if still present, tachycardia, lethargy, and minimal or no urine output. Patients can present with hypotension and signs of shock when severely dehydrated. Rx, mild to moderate, oral rehydration is initial step. Moderate to severe, immediate for resuscitation to restore perfusion and prevent end organ damage. Isotonic crystalloid is the only recommended crystalloid in children. Normal saline, hypotonic solutions are not recommended as can cause cerebral edema or electrolyte abnormalities. Dextrose solutions not given in initial therapy but should be added in maintenance therapy. REYE syndrome. Age 15 years, biopsy of liver, brain, and kidney, rightward arrow microvesicular steatosis, RX, supportive biliary cysts or choledochal cysts, congenital or acquired dilation of biliary tree. May be single, multiple, intra, or extrahepatic. If obstruction is suspected. Jaundice is due to obstructive cholestasis. Clinical presentation varies with age. Infants, jaundice and acolic stools, a presentation that resembles biliary atresia. Older children may have pancreatitis. Adults, vague epigastric or RUQ abdominal pain or cholangitis. Cholangitis presents with fever. Biliary cysts can transform into cholangiocarcinoma. Biliary atresia. First, progressive obliteration of extrahepatic biliary ducts connecting the liver to small bowel. Most common indication of pediatric liver transplant. Transplant presents in first 2 months with obstructive jaundice and acolic stools. Conjugated hyperbilirubinemia is always pathological. Conjugated hyperbilirubinemia, defined as 2 mg/dl of direct bilirubin or 20% of total bilirubin, without treatment, liver will become inflamed, e.g. hepatomegaly, hepatitis, and ultimately fibrose. Fatal without intervention. Virtually all PTS will require liver transplantation, but Kasai procedure will buy time for growth and downward arrow mortality and morbidity from transplantation. Physiologic jaundice appear after first 24 hours, days 2 to 4 of life. Unconjugated hyperbilirubinemia due to several physiologic differences. Differences in bilirubin metabolism. 1. At birth, RBC-CONC is upward arrow, HCT 50 to 60%, short RBC lifespan, 90 days, rightward arrow upward arrow HB turnover and upward arrow bilirubin 2. Bilirubin clearance is slow as hepatic uridine diphosphoglucuronate glucuronocyltransferase, UGT, does not reach adult level until 2 weeks of life. Asian newborns have downward arrow UGT activity as compared to other ethnicities. 3. Sterile newborn gut cannot break down bilirubin into urobilinogen to be excreted in stool. Rightward arrow, upward arrow, enterohepatic recycling of bilirubin. Rightward arrow, more bilirubin resorbed in gut until gut is colonized and produces more bacterial enzymes for reduction into urobilinogen, usually benign, and resolves in 1 to 2 weeks. Monitor for persistent or worsening jaundice, as high levels can cause brain damage. Suggest frequent feeding for gut colonization by bacteria and fecal excretion. Natural sunlight can downward arrow bilirubin but not recommended. Cox of risk of sunburn. Sometimes rapidly progressing hyperbilirubinemia is treated with phototherapy to prevent kernicterus development given if unconjugated bilirubin 20 mg/dl. Exchange transfusion needed if total bilirubin levels 25 mg/dl or there are signs of neurological impairment. Timeline of infant nutrition. Full-term infants don't develop iron def. Anemia until 4 to 6 mo of life as they are born with robust iron stores. Preterm infants, maternal iron def. An early introduction of cow's milk before 12 months age. Rightward arrow, upward arrow, risk of iron deficiency. Exclusive breastfeeding. Rightward arrow, upward arrow, risk of vitamin D deficiency. Hence, preterm, exclusively breastfed infants should be given iron and vitamin D supplementation. Iron supplementation should be started at birth and continue till 1 year age in preterm infants. Vitamin D, 400 IU daily, should be started within first month of life in exclusively breastfed infants. B12 supplementation is recommended to exclusively breastfed infants whose mother is a strict vegetarian. Pureed fruits and vegetables should be introduced first, followed by pureed proteins like meat. There is no evidence suggesting that early introduction of highly allergenic foods such as eggs is associated with an increased risk of allergies. These foods can be introduced any time after age 6 months. Although some fruit juices contain vitamins, the AAP, American Association of Pediatrics, does not recommend routine introduction of juice into an infant's diet. For families who choose to offer juice, no more than 4 to 6 ounces per day should be given, after age 6 months, and it should never be given in a bottle given the significantly increased risk of dental caries. Breastfeeding. Exclusive breastfeeding is the ideal form of nutrition for first 6 months and is highly recommended. Vitamin D supplementation is recommended till solids are started. Breastfeeding failure. Jaundice vs. breast milk jaundice. Hyperbilirubinemia that occurs is indirect, unconjugated, and may rise as high as 10 to 30 mg/dl. Breastfeeding failure. Jaundice, caused by both maternal and infant factors. Maternal, inadequate milk supply, cracked/clogged nipples, engorgement, infrequent feeding, e.g. 4 hours feeding interval, infant, poor latch, ineffective suck, falling asleep. Factors, normal infants, past dark, sticky meconium during first 2 days of life, after which they should transition to yellowish or green stool of ingesting adequate milk. Inadequate stooling. Rightward arrow, downward arrow, bilirubin excretion and upward arrow, enterohepatic circulation of bilirubin. Normal infant, during first week of life, normal no. Of wet diapers equals infant's age in days, e.g. 4 days old. Child equals / for wet diapers. Signs of dehydration, weight loss, downward arrow, urine output, brick red urate crystals in diaper, Rx, best treatment in otherwise healthy full term newborns. Upward arrow, frequency and duration of feeds to stimulate milk production, maintain adequate hydration, and promote bilirubin excretion in feces. Neonates should breastfeed 8 to 12 times a day, every 2 to 3 hours, for 10 to 20 minutes per breast during the first month of life. Closely monitor to ensure baby is fed adequately, remonitor in 2 days, and that his bilirubin level is decreasing. If the bilirubin continues to rise despite efforts to optimize lactation, formula supplementation may be necessary. However, discontinuing breastfeeding. Breastfeeding and switching to formula will further decrease the mother's milk supply and prevent the infant from receiving the benefits of breastfeeding, which include improved infant immunity and mother-infant bonding. Breast milk jaundice. It is generally a benign condition, but in rare cases phototherapy may be indicated. Beckwith-Wiedemann syndrome, BWS. Sporadic or inherited alteration in gene 11p15 rightward arrow encodes insulin, like growth factor 2 growth-promoting hormone similar to insulin. Some may have visceromegaly. Newborns must be monitored for hypoglycemia as fetal hyperinsulinemia can cause significant hypoglycemia, usually transient, and older asymptomatic PTS usually do not require monitoring. Screening for Wilms tumor and hepatoblastoma, AFP and abdominal USG, every 3 months from birth to age 4 years. Abdominal USG, every 3 months from 4 to 8 years. Renal USG, from age 8 through adolescence. Isolated hemihyperplasia are also at upward arrow risk of Wilms tumor and hepatoblastoma and require screening as above. Contents difference between small bowel obstruction and ileus. 2. Small bowel obstruction. 3. Paralytic ileus. 4. Dumping syndrome. 4. Peritonitis. Peritonitis. 4. Blunt abdominal trauma. 5. Management of blunt abdominal trauma in hemodynamically unstable patient. 5. Duodenal hematoma. 6. Pancreatic laceration. 6. Appendicitis. 7. Appendiceal abscess. 7. Psoas abscess. 8. Pilonidal disease. 8. Anal fissures. 9. Post-op cholestasis. Cholestasis. 9. Gastroenterology, surgery. Difference between small bowel obstruction and ileus. Small bowel obstruction. Upward arrow amylase and mild leukocytosis may be present. However, as SBO progresses, sounds may become diminished, and if ischemia occurs, they may disappear completely. Categorized by anatomical location, I.E. Proximal vs mid/distal, or simple vs strangulated, complete proximal obstruction, early vomiting, abdominal discomfort, abnormal contrast filling on X-ray. Mid or distal obstruction, colicky, abdominal pain, delayed vomiting, prominent abdominal distension, constipation, obstipation. Obstipation is severe or complete constipation. Hyperactive bowel sounds, dilated loops of bowel on abdominal X-ray. Simple, luminal occlusion, rightward arrow, no need of antibiotics. Strangulation/complicated, loss of blood supply to the bowel wall, rightward arrow, upward arrow, risk of ischemia. Strangulation, necrosis may have peritoneal signs, e.g. rigidity, rebound, change in character of pain. Signs of shock, fever, tachycardia, leukocytosis, significant metabolic acidosis are late findings. Rightward arrow, emergency abdominal exploration if not done. Upward arrow, risk of perforation and upward arrow, mortality rate. Cause, adhesions. More common cause, may be congenital in children, e.g. lad bands, but commonly arise from abdominal operations or inflammatory processes. Paralytic ileus, N/V, failure to pass stool or flatus. Obstipation, some degree occurs following most abdominal procedures but SX. 3 to 5 days post-op, rightward arrow, prolonged or pathological post-op ileus, PPI. Other causes, retroperitoneal/abdominal hemorrhage or inflammation, intestinal ischemia, and electrolytes abnormalities. Pathophysiology, increased splanchnic nerve sympathetic tone following peritoneal instrumentation, local release of inflammatory mediators, and postoperative opiate analgesic use, which causes decreased gastrointestinal motility and disordered peristalsis. Prevention, epidural anesthesia, minimally invasive surgery, and judicious perioperative use of intravenous fluids, to minimize gastrointestinal edema. DX, clinical mainly and abdominal X-ray findings rightward arrow dilated loops of bowel and no transition point, RX, mainly conservative and includes bowel rest, supportive care, and treatment of secondary causes. Dumping syndrome, drink fluid between rather than during meals. Common post-gastrectomy complication occur in 50% cases, loss of normal action of pyloric sphincter due to injury or surgical bypass rightward arrow rapid emptying of hypertonic gastric contents into duodenum and small intestine rightward arrow fluid shift from intravascular space to small intestine rightward arrow hypotension, stimulation of autonomic reflexes and release of intestinal VIP, DX, clinical, although upper GIX, Ray series or gastric emptying studies may be helpful if diagnosis is unclear, SX diminish over time. Minority with refractory symptoms may benefit from trial of octreotide or reconstructive surgery, but usually not needed. Peritonitis, management, 1. Pre-op nasogastric decompression. 2. For fluids and antibiotics. 3. If a PT is on warfarin rightward arrow reverse anticoagulation by restoring vitamin K dependent clotting factors with fresh frozen plasma, FFP. 4. Emergent laparotomy blunt abdominal trauma, most commonly injured organs, liver and spleen. Retroperitoneal organs like pancreas and duodenum are less commonly affected. Hypotension after BAT suggests solid organ or vascular injury, splenic laceration but hemodynamically stable and no evidence of other intra-abdominal injury. Rightward arrow may be non-operative management, signs of splenic laceration may appear late and initial evaluation may be unremarkable. Hemodynamically stable rightward arrow fast rightward arrow negative rightward arrow CT with contrast is the diagnostic modality of choice as it identifies splenic laceration with good accuracy. Also determines need for surgery, ESP. If spleen contrast extravasation is present, hemodynamic instability even after fluid resuscitation. Rightward arrow urgent laparotomy management of blunt abdominal trauma in hemodynamically unstable patient bedside abdominal USG or fast, focused assessment with sonography for trauma, performed. Retroperitoneal hemorrhage. If urgent laparotomy is performed in these PTS, it can lead to clinical deterioration, features suggestive of intra-abdominal injury, hypovolemic shock, seat belt sign, abdominal distension/guarding, rebound tenderness, concomitant femur fracture. FAST equals a convenient and effective test is bedside ultrasonography to detect free intraperitoneal fluid in the hepatorenal space, sphenorenal recess, and inferior portion of the intraperitoneal cavity. When combined with evaluation of the pericardium, this is known as the focused assessment with sonography for trauma, FAST, examination. DPL equals diagnostic peritoneal lavage. Rightward arrow determines presence of intra-abdominal hemorrhage if aspiration of 10 ml of peritoneal fluid shows blood. Rightward arrow intra-abdominal injury is likely, if no gross blood found. Rightward arrow perform peritoneal cavity lavage with normal saline. Rightward arrow effluent sent to lab for analysis, RBCs, duodenal hematoma, most commonly follow direct blunt abdominal trauma, more common in children. Blood collects between submucosal and muscular layer of duodenum. Rightward arrow obstruction. Rightward arrow epigastric pain and vomiting, CT with oral contrast. Investigation of choice, management, resolve spontaneously in 1 to 2 weeks. Intervention of choice, nasogastric suction and parenteral nutrition. Rightward arrow fails. Rightward arrow surgery. Focused laparotomy or laparotomy to evacuate hematoma. Pancreatic laceration, blunt abdominal trauma. Rightward arrow compression of pancreatic neck and / or body against vertebral column over which it lies. Rightward arrow pancreatic contusion, crush injury, laceration, or transection may result. Abdominal CT done immediately after trauma. Rightward arrow may not detect pancreatic injury, Serial CT scans required to detect evolution of injury. I.E. Enlargement of gland, parenchymal disruption, areas of diminished contrast perfusion, peripancreatic fluid collection, amylase values are non-specific. Rightward arrow do not aid in diagnosis. If blunt traumatic pancreatic injury is undetected initially, devitalized tissue or a pseudocyst resulting from such injury can become secondarily infected. Rightward arrow fever, chills, deep abdominal pain. Pancreatic abscess. Rightward arrow serious complication with upward arrow mortality, Rx, immediate placement of percutaneous drainage catheter, culture of drained fluid and surgical debridement. Appendicitis. Appendiceal abscess, if present 5 days. Rightward arrow can lead to contained abscess, CT scan for diagnosis. If stable. Rightward arrow bowel rest, for antibiotics and possibly percutaneous drainage of abscess. Urgent surgery has. Upward arrow risk of complications, PT may return 6 to 8 weeks later for elective appendectomy, interval appendectomy. Psoas abscess thrombocytosis may occur from hematologic seeding from distant infection or direct spread from intra-abdominal infection, e.g. diverticulitis, vertebral osteomyelitis. Risk factors, HIV, for drug abuse, diabetes, Crohn's disease, can present with non-specific symptoms, so it should also be considered as part of evaluation for fever of unknown origin. Deep palpation is needed to elicit pain. In PTS with unexplained PA, colonoscopy may be needed to find out the source of abscess, retrocecal. Appendicitis can also cause psoas sign, but pain is elicited by rectal exam and not localized to RLQ. Pilonidal disease, common in young males with larger amount of body hair. Etiology of pilonidal cysts/sinuses, unknown but believed to develop following chronic activity involving sweating and friction of the skin overlying the coccyx within the superior gluteal cleft. Infection of hair follicles in this region may spread subcutaneously. Rightward arrow form abscess. Rightward arrow ruptures. Rightward arrow pilonidal sinus tract. Chronic sinus tract may then collect hair and debris, resulting in recurrent infections and foreign body reactions. When sinus becomes acutely infected, rightward arrow pain, swelling, purulent discharge occur in midline post-sacral intergluteal region, sacrococcygeal skin, Rx, drainage of abscess and excision of sinus tract. Anal fissures. Post-op cholestasis, longitudinal tear in anal canal distal to dentate line, benign condition often develops after major surgery characterized by hypotension, extensive blood loss in tissues, and massive blood replacement. Jaundice is thought to develop secondary to 3 factors. 1. Increased pigment load, caused by the transfusion. 2. Decreased liver functionality, caused by hypotension. And 3. Decreased renal bilirubin excretion, caused by tubular necrosis. Generally, jaundice is evident by the 2nd or 3rd day after a prolonged surgery, with the bilirubin levels peaking at 10 to 40 mg/dl by the 10th postoperative day. Alkaline phosphatase levels can also be markedly elevated. The AST and ALT levels are typically normal or only mildly elevated. Contents: liver disorders unique to pregnancy. 2. Intrahepatic cholestasis of pregnancy. 2. Acute fatty liver of pregnancy, AFLP. 2. Pruritic urticarial papules and plagues of pregnancy. 3. Acute appendicitis in pregnancy. Pregnancy. 3. Gastroenterology-IM-SURGERY-MCCQE-V1 liver disorders unique to pregnancy. Intrahepatic cholestasis of pregnancy, functional disorder of bile formation, develops in 2nd or 3rd trimester of pregnancy, etiology unclear but thought to be hormonal, E.G. Upward arrow levels of estrogen and progesterone later in pregnancy, genetic and environmental factors influence, C/F, intense itching, often intolerable, generalized pruritus ESP. At palms and soles and worsens at night, evidence of skin excoriations may be present on examination. 10% have jaundice and require further workup. Labs, total bile acids upward arrow, may be the only abnormal lab. LFTs sometimes suggestive of cholestasis with upward arrow alkaline phosphatase and total and direct bilirubin, although alkaline phosphatase is upward arrow in normal pregnancy. Serum aminotransferases may be 10x upward arrow, 1000 at times, need viral serology, Rx, symptom relief and pruritus follows weeks after delivery. Ursodeoxycholic acid frequently prescribed to upward arrow bile flow and relieve itching. Maternal prognosis is generally good. However, early delivery is recommended once fetal maturity is achieved to avoid fetal complications, e.g., intrauterine demise, neonatal respiratory distress syndrome, acute fatty liver of pregnancy, AFLP, rare, serious illness that may present in third trimester, ultimately develop liver failure and extrahepatic manifestations like ascites, jaundice, hypoglycemia, encephalopathy, severe coagulopathy and acute kidney injury. Pruritus is not a common feature of AFLP, labs. Consistent with liver failure. Pruritic urticarial papules and plagues of pregnancy, skin condition that develops in the third trimester. Classic finding on abdominal examination is red papules within striae with sparing around the umbilicus, sometimes extending to the extremities. The palms, soles, and face are rarely involved, helping to distinguish it from ICP. There are no laboratory or liver abnormalities associated with PUP. Acute appendicitis in pregnancy may lead to ruptures appendix if diagnosis delayed 24 to 48 hours, N/V mimic pregnancy SX. RLQ pain is most common feature but location. Location may be higher depending on gestational age of pregnancy, fever may or may not be present, upward arrow leukocyte count may be present in appendicitis or normal pregnancy, USG with graded compression technique, non-compression and dilation of appendix diagnostic, best initial diagnostic technique and to rule out other causes. Non-visualization does not exclude appendicitis, if USG is non-diagnostic rightward arrow MRI is done to assess further for possible appendicitis, USG non-diagnostic. MRI not available rightward arrow only then CT can be performed rightward arrow diagnostic laparoscopy with last option, lower midline vertical laparotomy, contents gate disorders. Disorders. 6 cerebellar. 6 gate apraxia, Brunn's ataxia. 6 step page gate. 7